So Belinda, we had a great conversation when we met initially, but we wanted to take this a little bit further and actually do a formal interview with you that we can publish in our newsletter.
Okay.
So you're going to be the star of the show. So let's go ahead and get started, and we'll go through the questions. So how long have you been a peer support with MAHEC, and what is a peer support?
So I've been a peer support with MAHEC here for about 10 months now. A peer support is someone with lived experience in substance use disorder and or mental health illness that's currently in recovery. And in order to become a peer support specialist, you have to be in recovery for at least 1 year. We are able to meet the people or the person where they are, that being, at their residence, in their community, that being, if they're homeless at their campsite, anywhere where they are. We're also able to just relate to that person, possibly with what they may be going through and their struggles, and any type of social determinants of health. And we're able to assist them with the goals that they want to achieve within their lives to become a healthier person.
Okay. So tell us about your own personal journey through substance use disorder. What is your lived experience?
So my lived experience is I had a traumatic incident happen in my life. And throughout that traumatic incident, prior to that, like I just smoked marijuana, which, a lot of people don't think is really major, but it is in a sense, because it depends on each person's mental makeup, and that plays a part in that, any type of substance use. So I started using cocaine, and throughout my stint of using cocaine, it was about 8 months that I did. And I saw myself dwindling down, but I had support as far as outside friends and long down the line relatives. My immediate family didn't know anything about it because I didn't live at home. My support really came from like a really close relative of mine, and he was close to me, and a really good friend where they supported me throughout everything. They didn't change how they treated me. They only just talked to me and tried to encourage me. One of my biggest things, I think a lot of people fail to realize, is like someone that's already currently in substance use themselves, for them to try to give you advice about not doing the things that you're doing, you're like, how can you tell me anything? And that's kind of how I was. And his response was, because I don't ever want you to be like I am. And that was almost like a wake-up call for me. So I took a step back, looked at my life from like an outer perspective and how it was going and how it used to be. And myself, with their support, I did mind over matter. I decided that I liked my things and my money and the lifestyle that I had before. I got caught up in substance use, and I think it was more so because of a challenge that I had in my life that I just couldn't understand. I thought it wasn't right. God had abandoned me. Why did I have to go through this certain instance or a situation? And that kind of spiraled to where it led to. And then I decided just like I had to quit, and I did. And that's just kind of where I am today.
So I've got another question that I want to kind of piggyback on your story as you're sharing it. So the transition between marijuana and cocaine, what was that like, and how long did it take for you to bridge from one substance to the other?
So I didn't bridge. I just, as far as like wanting something more, because marijuana was always just like my calmness. It was what, kept me calm. It mellowed me out. It did, do anything like that. Like I'm very hyperactive, so it kind of mellowed me out. But when I started using cocaine, it was due to me wanting to not feel anything. And I didn't want to feel anything because of the situation that had happened. So that's what made me step out to another substance other than marijuana.
Did you do both at the same time, or did you go from marijuana to cocaine?
No, I did both at the same time.
Okay. All right. Well, thank you for sharing that.
Yeah, no problem.
So, how do you think your own journey is different, if it has been, to those peers that you support every day?
Um, in certain instances, it's different with certain people. It just depends on the person and what their situation could be. There are, all substances have a different reaction to each different person. And that's based off of the chemical imbalance that it causes within the person's mental health makeup and their brain capacity and how that works for that person. A lot of people don't have support. They don't have stability, housing, education, social determinants of health are like, you could check off maybe 5 boxes. There could be domestic violence or abuse and things like that in the home or within the family. And those are things that I never experienced. Because I came from a pretty great background and family, church oriented, raised and things like that. My major circle and people and family, were just of that sort. So I only experienced the life of drug use and drug selling and things like that because I decided to venture out into the world. Like they couldn't shield me from any of that because they didn't know what to tell me to shield me from. So it's kind of like I had to learn what I guess real life is really all about in the real world out there. When it came to those instances and situations, I run into some people that have had that same bringing up and things like that in their lives, that their parents did, of course, the best that they could because they told them what not to do, but not explaining exactly what could happen if you do this and things like, because they didn't know either. I think that's one of the biggest things that differs for me from other people that I made from the majority of my caseload, or that I encounter on a daily basis. I think that's the biggest difference between us. But when it comes down to the difficulty of being able to see ourselves, for who we are, sometimes even losing the lack of love for ourselves, even though the people around us may love us. All those things are the same. The lack of education about maybe longevity and long-term what this substance could do to you, having that lack of before you actually started using it, having the ability to not be able to just quit by yourselves. All those things are similar. I mean, they may, separate when it comes down to how long it may have taken me versus how long it may take someone else. But all those things are still pretty much the same because we all suffer from some type of stigma or lack thereof of something, which causes us to continuously stay in that same circle of substance use or mental health.
Wow. So, in general, what's the most difficult part of providing support to a peer?
Okay. So so that can be broken down into many different levels. It kind of all, yeah. So sometimes peers, just in general, sometimes peers allow their surroundings to influence their recovery or their goals that they want to achieve. And the most common and overlooked example is family. And I say that because, let's say, for instance, an individual, substance use disorder, is trying to get their life together, but because they're getting their life together, are involved in their family's life again, their family has expectations, requirements, check this box, check that box. I need you to do this, do that, because you weren't here for this amount of time, and things like that. And it overwhelms that person, and then they kind of fall back off the bandwagon and go back out into the world and feel like, well, what's the point of me doing it whenever, I mean, they're not seeing my improvement. They're not happy with what I'm doing. They still want more and more and more. And so they just feel like it's hopeless, you know, to do that. So that's one of the biggest things that I think a lot of people don't see. They don't acknowledge or show that acknowledgement to a peer. So that makes a peer revert back to that lifestyle again. And then one of the most other difficult things with a peer, with working with a peer, is they become overwhelmed. Like they're supposed to fill out an application for housing because, you know, they have to move within a certain time frame, or their lease is going to be up in 6 to 8 months, or whatever the situation may be. And then they don't follow through on their end, and then everything else falls apart. And then the peer wants immediate resolutions, which is almost impossible when other people are dealing with the same thing within the same society and element. So I think those are the two most difficult things to deal with the peer. If we went into different things, would be like making sure they keep appointments as far as coming into an office visit, or maybe even a telephone call. And I think the bridge in the very beginning of dealing with a peer is building that rapport. So that person knows that, okay, so we can still have this conversation or talk for this session or meet, even if you got high last night. I mean, like, it's not my place to judge you, but it's my place to make sure that you're safe. And if you're not safe, make sure I help educate you and help get you the resources that you need. Find out what the really root of the problem was or situation that caused you to use substances or go into psychosis or things of that nature.
Interesting. So I'll tell you what I always thought was the major issue, or would be the major issue. As a practicing clinician, one of the things that we always were taught to look for or help our patients guard against when they were battling substance use disorder is returning to the same environment where they started using. So I would have never thought that family pressures or expectations would be the thing that would tip them over.
Yeah, I've seen it. I've seen it a couple times in two different situations. One where one of my peers, the family is is wealthy and can afford to accommodate that peer with whatever they may need, even if that includes psychiatric treatment and things of that nature, that the family was uneducated about how those things work. So that peer felt as if they had to prove something, and they worked harder and harder, but they worked so hard and so fast that they tumbled backwards and fell right back into use again. And then another person where coming from incarceration, trying to get life together, child was put back into their lives. Oh, you're home. Well, here's your child. Can I get like a little bit of time to get myself together? Family didn't see it that way. You were gone all this time. I need you to do A, B, C, D, E, F, and answer when I call, even if myself and that peer were in a session that the parent or family member knew about. And I was like, hey, how you doing? Whenever the call came in the first time, but then it repetitively came in as if in, drop what you're doing because I need you to do this. And that
Wow.
person also returned to use as well. And it happens even with kids, adult kids, where parents may go through a stint of possibly wanting to return back or children not understanding that being a part of the MAT program helps them stop from using or takes their cravings away from actually using the substance that could harm them more.
Mm-hmm.
They don't quite understand it, and they want the parent to be completely abstinent, and then the parent tries it, and then boom, we have a return to use situation. So
Wow. Do you ever find yourself needing to engage family members around this particular issue so that the pressure is taken off of? I mean, as somebody who has this lived experience, you know what it's like when those stressors hit. So do you ever deal with the families of your peers?
yes, so sometimes we do, we make sure that we get like a release of information or consent to talk to that
Mhm.
person. And the reason being, oh, the way we have to incorporate that is more so holding a conversation with the peer and the parent or family member kind of at the same time,
Sure.
just to make sure that everything legitimately fits around how we're actually seeing the person and serving the person, especially if the family member is not a current patient of MAHEC. Now, if the parent is a current patient of MAHEC, then we just go through the realms of looping them into health education, and even trying to get them a part of a family support group for substance use disorder.
Mhm.
Um, and we'll find some of those that they can attend online, and different webinars and things of that nature that they can kind of look and really educate themselves on. So sometimes we do have to, but it's only at the peers' discretion, and them wanting to include that parent or family
Mhm.
member in the knowledge of their recovery.
Mhm. Mhm. Okay. So tell us about the socioeconomic and ethnic makeup of your peer group, those that you engage with on a regular basis.
So my caseload is diverse. So it has males and females of Caucasian descent, females of African American descent, females of Russian descent. Um, I have families that, or peers that are wealthy. Um, I mean, like trust fund children. I have people that are less fortunate, homeless, some that are completely supported by their family, some that are supported more by their family, and the peer actually doesn't want to engage as much.
Mm.
Um, and then I have individuals that want it so bad, and they just don't have the support outside of peer support or their physicians and healthcare providers, that um, they just can't figure things out for themselves, or nobody else is outside of that window of like 8 to 5.
Mhm. So how do you feel the approach to managing your peers from minoritized groups can impact their success for recovery?
Um, so I think it would really depend on how the groups were broken up. And I say that as in to say, or relating back to myself, like if I was in a group with more African American females and things of that nature, would I feel as though I wouldn't belong because I can't talk about what it's like growing up in poverty or less fortunate environments and things of that nature. So myself, like I might feel a little out of place. But then would they feel as though I felt like I'm more than? Would I feel like I had to explain myself? And, I'm aware of those situations. Um, I think it could pose a lot of success for certain individuals because it gives them more of a common ground to kind of stand on so that they can relate to someone else. Um, and they can see the success that some have made and can reflect off of their own mishaps and maybe offer other suggestions for other individuals. I think that is the ultimate plus when it comes down to that. It's also going to really be based off of the mindset of, of course, any individual person in any group, whether or not they have an open mindset to understanding it and accepting, or a closed mindset to whatever you say is kind of wrong and that's not how it should be type situation. I think it really just all depends on the make of the entire group. I think overall, maybe like if we were doing a percentile ratio, I think maybe 75 to 85% would be successful and productive. And then the other percentage would either, fall back or not feel or feel secluded in some type of way.
So from an individual standpoint, do you think, let's say, African American peers or Latinx peers are more difficult to get to the point of success than your Caucasian peers
Um,
in terms of their recovery and then being able to maintain their sobriety?
so in all actuality, with the peers that I have dealt with, I think it's pretty much a 50-50 ratio. And that's just with my own caseload and the peers that I deal with. And I say that because it's harder to get more Latinx and minorities engaged in the services in the very beginning. Now, once they're engaged and once you build that rapport with them, it's a much smoother transition. But maybe getting minorities to try something different, to step outside of their comfort zone, is more difficult than it is for individuals of Caucasian descent.
Okay. Talk a little bit more about that. Do you have any thoughts as to why that is?
So it could vary on whether or not what they've seen in life, what they've been through in life, or the fact that they're just comfortable where they are. It also could vary on the fact of them not having the knowledge of other things in life that they could be successful at. And some of those things in life that they could be successful at is still stigmatized against, where they are not given that opportunity because of their descent, because of their background. And they feel as though it's a target already on their back. And that right there stems back to the point of, why should I do it anyways? I'm already deemed to not be successful. So, what's the point? I might as well stay where I'm at. Why do all this hard work? And then, nothing's really going to happen or change. And that's sometimes how that flows into the lifestyle of just the color of their skin or the stigma that's already placed upon that individual. I can say for myself, if I don't, at my job, I don't have to worry about it, or the people that I know and deal with. But if I just go to a random place and I have on a fitted hat and sweatpants or something like that, and I go into, let's say, Macy's or something, I'm going to have that look. But if I go into Macy's with my button up shirt, and dress pants, then I'm okay. If my dreads are up, if my dreads are down, it's a different story. You get that look or that stigmatized feeling that's placed upon you, regardless of if you go to Ross or if you go to Five and Below, like right here in Asheville. I've seen it happen, and that's one of the hardest reasons why minorities don't want to put in that work to do it, because they already know that they're stigmatized against, and or they already feel like it's not going to make a difference in their lives. And or they feel like they're going to have to work harder to get the same thing that somebody else can get with less work.
That's interesting. It puts things in a completely different perspective from me. There's the external stigma and then there's the internal stigma. So somehow those of us that do this work have to change that narrative before the individual sees that it's worth the journey.
Exactly. Exactly.
Wow.
And sometimes that comes into play with having, and this will kind of roll into one of your other questions, but kind of comes into play with, if you're not familiar with something, always, finding out so that that person can feel validated and their points are being appreciated, and as well as incorporating peers in all forms of healthcare from all different backgrounds, because each person brings something different to the table. And, you know, not forgetting where you are and where you've been and how you got there, and making sure that you always stay humble within yourself, that hard work.
Yeah, this brings back a point to something that I read several months ago as I was preparing to write another piece, that race and ethnicity is a social determinant of mental health.
Oh, definitely.
Yeah, and which is not something honestly that I even thought about. I mean, with those of us that work in healthcare are familiar with the social determinants of health, but learning about the social determinants of mental health was an eye opener for me. So,
Yes.
and you're speaking exactly to that right now. So good. This is good stuff. This is really good stuff. Tell us about the types of providers you team with as a support. Have you worked with PAs on your clinical team? I think we talked a little bit about that
Yeah, so we don't
previously.
so we don't have PAs here at MAHEC. But we work with any and everybody that works at MAHEC. So it could be any front desk staff that thinks that, a person could benefit from peer support, because sometimes, a person might come in, hey, how you doing today? And, oh, I'm not so good. And then they just kind of talk about it because they've seen this person a lot when they come in. CMAs, we do work with medical doctors. We do work with school-based therapists. So the
Mm-hmm.
therapists work in a school, and let's say a parent maybe having issues with parenting or other resources or homelessness or things of that nature. So they'll refer the parent. Psychiatrists, we work with the OBOT team, which is opioid-based outpatient therapy.
Mm-hmm.
Family medicine, internal medicine, interns, residents, psychiatrists, psychologists, anybody that works within MAHEC that may feel as though they're seeing someone or interacting with a patient, they may refer that person to peer support services. Internally, we also work with different external organizations
Mm-hmm.
where they may even make a referral to um, a peer support specialist within our team.
So, do you think the team could be enhanced by having PAs participate in the or being available to the peers that you work with?
So, I think anybody that's in healthcare that is all about the person's whole health, because I mean, like I looked up the PAs and the difference between all of them and stuff like that. Um, I think that it would be beneficial to not only for peers to have PAs, but for PAs to have peers as well, work with them, and to collaborate together. And I say that because a lot of times a physician, a peer, like, I mean, I've seen a PA before and they'll tell me something and I'm like, can you say that I need to understand it. Like, can you tell me that in layman terms, please? So I think that sometimes the peers don't understand exactly what providers and PAs are saying and things of that nature. Whereas the peer can come in and talk about, so this is what they're really meaning, like that bridge between the two of them. And I think that that will be beneficial to any peer, anybody
Mm-hmm.
out here that needs some type of assistance with substance use disorder or mental health illness.
I think what we need to arrange, particularly with, because I have this relationship with MAHEC and I've had it for a couple of years now, arrange for some of our students in the state to actually work with you and work with peers so that they could see. I think incorporating that as part of their training would give them a little bit broader base, just in addition to putting them in a clinical setting where MAT is being offered. So they see that part of the management of the person that is struggling with substance use disorder, but to actually see the psychosocial pieces, which is the role that you play,
Right.
I think would enhance the training and allow PA students to be able to see the value of the peer support relationship. So,
Oh, definitely, definitely, because anybody that is licensed, just as yourself, or PAs or doctors and things of that nature, they only have but a small window to see this person, and they only can contribute but this type of service or this type of service. And those services sometimes can be bridged together internally, but only through like a message. They can't be bridged together through actual conversation or actually seeing, that person. Whereas myself, it's more of an informal situation. It's and I don't want to say, I guess code switching would be the technical terminology for how we have to, or how we engage in a person's life. And that's because, we want that person to feel comfortable. We don't ever want that person to feel like we think that we're better than, because we're not.
right.
So we are more laid back, like, hey, what's going on? How you doing today? Type situation where, it's not, hi, how are you? It's very much informal, and a lot of providers cannot, provide that type of service to an individual.
Right,
Sometimes
right,
that's what they need.
right. Understood. Okay. So tell us about your experience with your peers who are recovering with the use of MAT, a medication assisted treatment,
Um,
specifically.
okay, so um, I have a couple of individuals that are a part of the MAT program. One of those individuals actually just completely came off of the MAT program.
Mm,
And that was due to the fact of trying to do like the 12-step programs, and um, in NA, if I'm not
hmm
mistaken, NA.
There
Yeah,
seems to be this clash between the philosophies of
exactly. The clash
12-step
between the
programs and MAT, those of us who are proponents of MAT. I think you can have the best of both worlds, but that's just me. So let's
right.
hear.
So there is a difference in the philosophies, whereas you have to be completely abstinent from all substances. And if you're not completely abstinent from all substances, that means that if you're a part of the MAT program, then they won't work the steps with you. So that's what
Hmm
one of my individuals was dealing with.
hmm
And they felt as if, they were less than the other people that were also attending. And
hmm
they felt as if they were shunned upon, or if they were not accepted or not treated equally. And so with that, it kind of threw that stigma against them, to where, like, they don't have anywhere to go. They don't feel welcome. They don't feel wanted, even though their sobriety is not doing any other substances other than what is prescribed to them for their medication assistance treatment.
hmm
And I mean, and staying on track with that. So that reverted that individual back into active use every once
Oh,
in a while. And then, come back and try it again, and come back and try it again. And then they just decided throughout their, actually, they went to a psychosis state. They actually came off and was weaned off of all medications, and they decided to stay off of their medication-assisted treatment medications. So I will say that it is so far been successful for that person, but everybody's a little bit different. Another individual, three individuals that are also on are involved in the MAT program. One of the biggest struggles that I see with some individuals is that, you know, they have to come to their doctor's appointments, they have to do the drug screening and things of that nature to make sure that they're not using, of course, other substances along with this because of the interactions and the medical piece that goes along with that. And they either miss their appointments or wait until they're completely out of medications and need a bridge. And instead of coming in or just saying, hey, I slipped, they will maybe go out and use their preferred substance instead of, you know, complying with some of the requirements to be a part of the MAT program. We have some individuals that are completely successful, and that program has taken them from their active use of substances to a coherent and healthy lifestyle, even still being a part of the MAT program. And actually, a dear friend of mine, that person just actually winged off of the MAT program that they've been on for 3.5, 4 years now. And, you know, successful. I mean, has taken classes alongside me the entire time, you know, while being a part of the MAT program, and has successfully come off and is continuously being successful. So I think it just really all depends on the type of stigma that's placed around MAT itself and the type of engagement with other individuals, or a person's personal perspective about MAT as well can play a role and a part in how successful or non-successful that a person can be on MAT.
Okay, so that swings us into the next question. What role do you feel stigma plays in the recovery of your peers?
Well, whether or not they're on MAT, whether or not they have a background, that plays a big role in it. Whether or not an individual is educated enough to know about mental health and substance use disorder, or whether or not they don't know anything about it, that stigma that's placed on it there. The stigma of past events of a person's life or lifestyle, the fact of if they are still currently residing in the same area that they were in active use. And sometimes because somebody knows somebody that knew you back then, it kind of plays a role in it too. And things of that nature. I think that those are a lot of the big stigma factors that play a role in whether or not a person can be successful or unsuccessful in recovery. And it also will balance out to whether or not that person is strong enough to say, you can think whatever you want, you can believe whatever you want, and I'm going to prove you different. So it kind of just depends on whether or not they're that passive or aggressive person, optimistic or pessimistic person as well, and whether or not they have that support to continuously reassure them that what they're doing or that they're making progress in the right steps.
So your role as a peer support, how do you handle someone who may feel the sting of stigma coming from the environment where they once used. So I guess the best example I could give you would be somebody who, again, may be returning to the community where they were actively using, but now they're on MAT. But the folks that they were engaged with when they were in active use are stigmatizing them. What does that look like? Or how do you play a role in helping them to manage being in that environment, although they're now part of the MAT program?
So, my personal belief is I never let my left hand know what my right hand is doing.
Okay.
So that means that if those people are not engaged, if the people in the community that they used to deal with in that manner are not a part of their recovery, my first thought to that person would be, have you told them that you're part of the MAT program? Do you feel as though you need to tell them that you're a part of the MAT program? Or is just saying that you're in recovery or not using those substances anymore sufficient enough? I mean, do you feel as though you have to give an answer? I mean, I guess that's where I would probably start off with, because I mean, if they feel as though they need to validate themselves in some sort of way, then that is pretty much where I think the root of the situation would be. Or if they didn't want to make those individuals feel as though they were less than without them seeing that they were more than, I guess I would pretty much have to fill out, what the actual thought process and stigma that the group would try to inflict on the peer based off of their former engagements. And then more so, I guess, I would do a role play type situation. Like, what would happen once they gave me kind of like an outline of how the people or individuals would look at them. I would give them a breakdown of, hey, so what do you do if this, and this, and kind of let them shoot things off me on the fly or tell me how they would respond and what they want but don't want to include, because it's a different conversation where you used to tell these individuals all your business, where you got this and that from and how much, and we'll go see this person for that, versus being sociable but reserved about your personal information.
Yeah. That sounds like a good approach. I like the role play piece because it gives them an opportunity to see themselves in that situation that they may be ultimately confronted with.
Yes.
All right, so from your experience as a peer support, what lessons have you learned that PAs and other clinicians can apply to caring for those with opioid use disorder or substance use disorder?
So we're all learning from textbook, and we learn as we actually engage with the person. Textbook is, normal standard knowledge of different arrays of how things could be and the practice that we should follow. Although making sure that we show equality and equity all in the same realm, we have to first acknowledge ourselves and what we know, but what we don't know. So what I've learned is when I engage with individuals after, of course, learning textbook material, but specifically with individuals that use substances that I've never engaged with in my entire life or didn't even knew that existed or anything of that nature, I acknowledge that. So I'm not familiar with that. So if you're comfortable enough, let's talk about it, and that opens up a door to where you actually learn more about that individual person, the situation, what they feel, their actual emotions, thoughts, and things like that, that you would probably never get out of an individual if you just ask them basic questionnaire questions. And that also gives that person a sense of empowerment to say, oh, I can teach this person that went to school for 6, 7, 8 years, something that they don't know. And it's like, you know, I matter, I mean something, I can educate someone, you know, and then giving them that acknowledgement later on, especially whenever, you know, they feel down on themselves or something's going on. But hey, remember, you are the one that taught me how to acknowledge this or how to see this or how this goes. And, you know, they see that and they're more responsive to that. I think that that's one of the affirmations is a big piece and giving it to the individual, as well as not acting like you know everything about everybody's recovery, because everybody's recovery is different. Everybody's situation is different.
So here is your opportunity to dream. So if you could change anything about the systems of care that provide treatment to those suffering from opioid use disorder or substance use disorder, what would you change?
I think one of the biggest things is awareness and use of cross-cultural equality. I think that, you know, what person is better to actually teach individuals about substance use or opioid use than the people that are actually doing it. I think that you know, right now we have peer supports that have been incorporated into the healthcare world that are in recovery to provide services to individuals on a non-medical field. But I think that, I mean, in my all honest opinion, like I would love for them to just take opioids like completely off, like go back to just anesthesia and things like that for medication instead of so much opioids being prescribed and given out and things of that nature. But I think that there's a lot of people that are not aware in the younger ages of individuals that should be aware of what opioids can do to individuals and to themselves. I think that whenever providers are giving treatment to people that are suffering from opioid use disorder, substance use disorder, need to treat each individual individually and not on a scare tactic. I see some people and have heard of some people being prescribed opioid or a medication assisted treatment program because they used opioids, let's say 7 years ago, and that was the last time they used it and haven't used anything. And then all of a sudden, because they're having a lot of stuff and stresses going on in their life, oh, well, let's put you on some medication to Suboxone to keep you from having cravings. But you know, I didn't say I had cravings type situation. That happens. That
Really?
happens. Yeah, it happens because some providers use that as a they use the MAT program to, because they don't want the person to go out and use a substance. So it's more like they're scared that a peer or person may go back into active use of opioids. So we're going to put you on something to block it. But yet that's, to me, getting you addicted to the MAT medication instead of just, you know, constant or more visits or counseling or therapy and things of that nature. I know 2 people personally that has happened to. So that's why I can kind of attest to that being something that happens a little more often than what should happen.
So if I'm hearing you correctly, you're saying that there should be a more responsible use of MAT than what you have experienced as a peer.
Correct.
Interesting. Okay. Okay, I would like to dig into that a little bit more, but we don't have time. We'll have another conversation about that.
Okay.
So what would you like to share with PA educators, PA students, practicing PAs that they need to know that would help them understand the complexities of opioid use disorder, treatment, and recovery?
Um,
This is your last question.
I think that's the most, I think the most important part that a lot of people overlook because, you know, like I say, everybody has a guideline that they have to follow. You know, like if a person complains of back problems in the lower right quadrant, then it could be their kidneys or things of that nature. So they might need to drink water, or they might have, you know, a urinary tract infection. But with that, when someone is talking about opioid use disorder, or anything of that nature, they have to always remember that every person is different. You know, finding out what this person what this person does, has done, and things of that nature in their life is most important. How long ago they done it, how much they done whenever they done it last, what was their active average use. And when you start probing and asking a lot of those questions, you know, that person may get a little like you're nosy, or you're asking me too many questions, or they feel like you are that's too much information that they actually want to give. And with that being said, then that comes down to the fact of making sure that they express that the reasons why. As long a lot of times, as long as people know why you're asking me so many questions, like don't ask me, have you ever been to prison before? Because I want to know why. Are you asking me because I have dreads, or are you asking me because I'm African American, or are you asking me because I have on a sweatsuit? Like just the simplicity of those things and people knowing why the question is being asked is most important. Everybody's story is different. That means every treatment plan is going to be different. Every success story had a different path, and on each person's path, their stumbling blocks are going to be different.
Mm.
And those are like the most important things. And finding out what the actual root of the situation or reason why that person started using substances. Because I mean, even whenever I started using cocaine, I did not know what the reason for me using cocaine was until, you know, later on in life. And I sit back and I think about it and I'm like, this is what happened. And that's why, because I mean, it was there before. I mean, I have entangled with substances and dealing them throughout a lot of my younger life that my family didn't know about. And
Mhm.
I shielded that from them. But there is always a root to everything, a reason
Mhm.
why we do this and we do that. Same way it's a reason why we get up and we go to work every day, or why they became a PA, is there's a reason why that person used substances. And we
Mm.
got to figure that out in order to, you know, really fix the problem and help that person heal internally.
You just gave me chills, my dear. This has been amazing.